Federation for Mental Health to spread awareness around the world. The theme this year is Creating Hope Through Action, which encourages all of us to consider the role that offering support may play in combating suicide. We are all part of a community, linked to family, friends, work colleagues, neighbors, or teams. Sometimes we become isolated and disconnected from our communities. Social connectedness reduces the risk of suicide. So being there for someone who has become disconnected can be a life-saving act. We have the responsibility to support and empower those who become vulnerable in our communities. If you are worried about someone in your community, reach out and ask them, are you okay? By simply checking in with them and offering non-judgmental support, you can make a difference. It is important to know that people in distress are often not looking for specific advice, but merely to be listened to with compassion and empathy. We warmly welcome all those present today who have accepted our invitation and have joined us to remember those who have chosen to end their lives having found living unbearably painful. We will also remember those survivors whose lives have been shaken by suicide of a loved one and hope that they will be able to gather strength and support to cope and walk ahead in their lives. Sumithrayo has been around since 1974 to support and empower anybody going through a crisis in their lives. We kindly request that you join us in lighting a candle wherever you are with individuals from all over the world in support of World Suicide Prevention Day at 8 p.m. this evening to remember a lost loved one and the survivors of suicide. Thank you.
සැප්තැම්බර් 10 වෙනි දිනට යෙදී තිබෙන ලෝක සියදිවි හානි කර ගැනීම වැළැක්වීමේ දිනය 2003 වර්ෂයේ සිට සැමරීම සිදු කරන්නේ විශේෂයෙන් ඒ පිළිබඳ දැනුවත් කිරීමේ දිනයක් ලෙසයි. ලෝක සෞඛ්‍ය සංවිධානයත් මානසික සෞඛ්‍ය පිළිබඳ ලෝක සංවිධානයත් සම්බන්ධ කර ගනිමින් ජාත්‍යන්තර සියදිවි හානි කර ගැනීම වැළැක්වීමේ සංවිධානය සියදිවි හානි කර ගැනීම වැළැක්වීම සම්බන්ධයෙන් දැනුවත් කිරීම ලොව පුරා සිදු කරනු ලබනවා. මෙම ආශය තේමාව වන්නේ ක්‍රියාව තුළින් බලාපොරොත්තු ඇති කිරීම. තම පවුල් ලේඛකය, මිත්‍රයන්, රැකියා ස්ථානයේ සගයන්, අසල්වාසීන් යන විවිධ කොටස් හරහා එකම සමාජයේ කොටස්කරුවන් වන අප සියලු දෙනාටම උදව් කිරීමට ඉදිරිපත් වීම මගින් දිවි හානි කර ගැනීම වළක්වා ගැනීමට හැකි බවට දිරිගැන්වීමක් මෙම තේමාව හරහා සිදු කෙරෙනවා. සිය දිවි හානි කර ගැනීමේ අවදානම අඩු කරන සාධකයක් වන්නේ සමාජ බැඳීම්, ඇතැම් අවස්ථාවලදී අපහුදකලා වීම සහ සමාජයෙන් වෙන් වී සිටින අවස්ථා දක්නට ලැබෙනවා. එවන් අවස්ථාවලදී එලෙස හුදකලා වී හෝ සමාජ සම්බන්ධතා වලින් වෙන් වී සිටින පුද්ගලයන් වෙනුවෙන් කාලය යොමු කිරීම හා ඔවුන්ට උපකාර කිරීමට ඉදිරිපත් වීම ඔවුන්ගේ ජීවිතය ආරක්ෂා කිරීමට පවා හේතු වනවා. එලෙස අවදානමට ලක් වී ඇති පුද්ගලයන් කෙරෙහි අවධානය යොමු කර ඔවුන්ට උපකාර කිරීමත් නිවැරදි තීරණ ගැනීම උදෙසා ඔවුන් දිරිගැන්වීමත් අප සමගයේ වගකීමයි. ඔබ ඔබට සිටින කිසිවෙකු හෝ පිළිබඳ ඔබ කනස්සල්ලෙන් සිටිනා ඔවුන් වෙත ඔබගේ අවධානය යොමු කොට ඔවුන්ගෙන් ඔබ හොඳින්ද කියා අසන්න. එම සරල ප්‍රශ්නය ඇසීමෙන් සහ ඔවුන් ගැන කිසිදු විනිශ්චයකින් තොරව උපකාර කිරීමට ඉදිරිපත් වීම මගින් ඔවුන්ගේ ජීවිතය තුළ විශාල වෙනසක් ඔබට සිදු කළ හැකියි. අප විශේෂයෙන් තේරුම් ගත යුතු දේ වන්නේ පීඩාවට පත් වී සිටින පුද්ගලයෙකු සෑම විටම අවවාද බලාපොරොත්තු නොවන බවත්. ඔවුන් විශේෂම බලාපොරොත්තු වන්නේ සානුකම්පිතව සහ සකම්පනයෙන් යුතු ඇහුම්කන් දීමත් බව. ජීවත් වීම ඉතා වේදනාකාරී බව සිතා සිය ජීවිතයෙන් සමුගත් සියලු දෙනා සිහි කිරීමට අද දිනේ අපගේ ආරාධනය පිළිගෙන අප හා සම්බන්ධ වී සිටින ඔබ සියලු දෙනා මේ අවස්ථාවේදී අපේ ඉතා ආදරෙන් පිළිගන්නවා. තවද එයින් දිවි බේරාගත් අයද තම සමීපතමෙකුගේ සිය දිවි හානි කර ගැනීමක් නිසා තදබල ලෙස කම්පනයට පත් වූ සියලු දෙනාද මේ අවස්ථාවේදී අපි ඉතා ආදරයෙන් මතක් කර සිටින අතර ඔවුන්ට ශක්තිමත්ව ජීවිතයට මුහුණ දීමට අවශ්‍ය ශක්තිය හා උපකාරය ලැබේවා කියයිද අප ප්‍රාර්ථනා කරනවා. 1974 වර්ෂයේ සිට පීඩාකාරී අවස්ථාවලට මුහුණ දෙන ඕනෑම කෙනෙකුට චිත්තවේගී යහපැවැත්ම පවත්වාගෙන යාමටත් නිවැරදි තීරණ ගැනීම සඳහා දිරිගැන්වීමටත් තම සේවය සැපයීමට සුමිත්‍රා ආයතනයේ කැපවී සිටින බවත් මෙම අවස්ථාවේ මතක් කර සිටිනවා. ලෝක සියදිවි හානි කර ගැනීම වැළැක්වීමේ දිනය සනිටුහන් කරමින් අද රාත්‍රී 8ට ඔබ සිටින ස්ථානයේ සිටම ලෝක පුරා සිටින සියලු දෙනා සමග එක්ව සියදිවි හානි කරගත් සහ එයින් දිවි බේරාගත් ආදරණීයයන් සිහිපත් කරමි. අප හා එක්ව පහනක් දැල්වන මෙන්ද අපි ඉතා කරුණාවෙන් ඉල්ලා සිටිමු. ස්තුතියි. நந்தினி.
எஸ், வணக்கம். உலக தற்கொலை தடுப்பு தினம் என்பது 2003ஆம் ஆண்டு முதல் ஒவ்வொரு ஆண்டும் செப்டம்பர் 10ஆம் தேதி விழிப்புணர்வு தினமாக அனுசரிக்கப்படுகிறது. இது உலகளாவிய அர்ப்பணிப்பு மற்றும் தற்கொலைகளை தடுக்க நடவடிக்கை எடுக்கிறது. உலகெங்கிலும் விழிப்புணர்வை பரப்புவதற்கு வலி ஆய்வுக்கான சர்வதேச சங்கம் உலக சுகாதார அமைப்புடன் ஒருங்கிணைந்து மற்றும் மனநலத்திற்கான உலக கூட்டமைப்பு ஆகியவற்றுடன் ஒத்துழைக்கிறது. இந்த ஆண்டு கருப்பொருள் செயல் மூலம் நம்பிக்கையை உருவாக்குதல். இது தற்கொலையை எதிர்த்து போராடுவதில் ஆதரவை வழங்குவதற்கான பங்கை கருத்தில் கொள்ள நாம் அனைவரையும் ஊக்குவிக்கின்றது. நாங்கள் அனைவரும் ஒரு சமூகத்தின் ஒரு பகுதியாக இருந்து குடும்பம், நண்பர்கள், பணிபுரியும் சக ஊழியர்கள், அண்டை வீட்டார் அல்லது குழுக்களுடன் இணைக்கப்பட்டுள்ளோம். சில சமயங்களில் நாம் தனிமைப்படுத்தப்பட்டு நமது சமூகங்களில் இருந்து துண்டிக்கப்படுகின்றோம். சமூக தொடர்பு தற்கொலை ஆபத்தை குறைக்கிறது. எனவே துண்டிக்கப்பட்ட ஒருவருடன் இருப்பது ஒரு உயிரை காப்பாற்றும் செயலாகும். எங்கள் சமூகங்களில் பாதிக்கப்படக்கூடியவர்களுக்கு ஆதரவளித்து அதிகாரம் அளிக்கும் பொறுப்பு எங்களுக்கு உள்ளது. உங்கள் சமூகத்தில் உள்ள ஒருவரை பற்றி நீங்கள் கவலைப்பட்டால் நீங்கள் நலமா இருக்கிறீர்களா என்று அவர்களிடம் கேளுங்கள். அவர்களின் நலத்தை விசாரித்து பாராபட்சமின்றி ஆதரவை வழங்குவதன் மூலம் நீங்கள் மாற்றத்தை ஏற்படுத்தலாம். துன்பத்தில் உள்ளவர்கள் பெரும்பாலும் குறிப்பிட்ட அறிவுரைகளை தேடுவதில்லை. மாறாக இரக்கத்துடனும் அனுதாபத்துடனும் முனைப்புடன் செவி மடுக்க வேண்டும் என்பதை அறிவது முக்கியம். எங்களின் அழைப்பை ஏற்று தாங்க முடியாத வேதனையுடன் வாழ்க்கையை முடித்துக் கொள்ள தேர்ந்தெடுத்தவர்களை நினைவு கூற எங்களுடன் இணைந்திருக்கும் அனைவரையும் இன்று அன்புடன் வரவேற்கின்றோம். நாம் நேசிப்பவர்களின் தற்கொலையால் இன்னும் உயிருடன் இருப்பவர்களை நினைவு கூறுவோம். மேலும் அவர்கள் தங்கள் வாழ்க்கையை சமாளிப்பதற்கும் முன்னேறுவதற்கும் வலிமையையும் ஆதரவையும் சேகரிக்க முடியும் என்று நம்புவோம். சுமித்ரியோ 1974ஆம் ஆண்டிலிருந்து அவர்களின் வாழ்க்கையில் நெருக்கடிகளை சந்திக்கும் எவருக்கும் ஆதரவளித்து அதிகாரம் அளிப்பதற்காக செயல்பட்டு வருகிறார்கள். உலக தற்கொலை தடுப்பு தினத்திற்கு ஆதரவாக இன்று இரவு 8 மணிக்கு தற்கொலையாய் இறைவனடி எய்தியோரை, தற்கொலை முயற்சியில் ஈடுபட்டு உயிர் பிழைத்தவர்களையும் நினைவு கூறும் வகையில் உலகம் முழுவதிலும் இருக்கும் தனி நபர்களுடன் நீங்களும் எங்கிருந்தாலும் மெழுகுவர்த்தி ஏற்றி எங்களுடன் சேருமாறு அன்புடன் கேட்டுக் கொள்கின்றேன். நன்றி.
Thank you. I would like to very warmly welcome our panelists today, Dr. M. Ganeshan, consultant psychiatrist who was formerly attached to the NIMH, Dr. Neil Fernando, senior consultant psychiatrist and senior lecturer at Kotalavara Defense University, and Dr. Shiromi Malwtte Mohotti, acting consultant community physician, Directorate of Mental Health. I invite Dr. Shiromi Malwtte to kindly begin her keynote speech.
Thank you. I need to share my screen. I need to share my screen.
I think you can do it. Is it not showing up? You can. I think you're given the. You can click on share screen. Is it happening? Arosho, can you help Doctor, please?
Dr. Shiromi, you can share the screen.
Yes. Can you see it?
Yes, we can.
Yeah. Creating hope through action. Thank you for Sri Lanka Sumithrayo for giving me this opportunity. I am Shiromi, representing the Directorate of Mental Health, Ministry of Health. And also, it's a pleasure to share this platform with two eminent consultants, Dr. Ganeshan and Dr. Neil. Today is World Suicide Prevention Day, 10th of September. And why we are speaking about this is that suicide is preventable. And our target is to reduce suicide mortality by 1/3 by year 2030. We have, as the Ministry of Health, Directorate of Mental Health, we have pledged to reduce suicide by 1/3 by year 2030. And if we go back in time, in 1995, we had 8,000 odd suicides. But in the recent years, if you take the last 10 years, you can see the trends. It's fluctuating. The numbers are between 3,000 to 3,500. And last year, we had 3,406 suicides. We have obtained this data from the Department of Police. And if you look at the last 3 years, there is no significant increase in suicides. It's all fluctuating between 3,000 to 3,500. And if you look at 2022, 2023 first quarters, because still the data is available for the first quarter, second quarter data is still not available for 2023. Again, the numbers are a bit similar, 830, 816. And if you look at 2022 district-wise, we see Gampaha and Kurnagal district topping the list. And if you take the first quarter of this year, again, Gampaha and Kurnagal is topping the list. And if you look at the reasons for the last 3 years, 2020, 21, and 22, harassment and family disputes, mental disorders, chronic diseases, physical disabilities, disappointments, addiction to narcotics, economic problems, and the rest are considered as other. And if you look at the methods, hanging is the most common method. In year, if you take all the years from 2018 to 2022, hanging is the most common method. Then the ingestion of pesticides, drowning, setting fire on oneself, jumping in front of moving vehicles. The Directorate of Mental Health, Ministry of Health, this was established in 1998 as the national focal point to have the conduct the National Mental Health Program. සෞඛ්‍ය අමාත්‍යාංශයෙන් මේ සෞඛ්‍ය පිළිබඳ මානසික සෞඛ්‍ය පිළිබඳ අධ්‍යක්ෂ කාර්යාලයේ 1998 පටන් අරගෙන තියෙනවා National Mental Health Program එක. එහෙම නැත්නම් මානසික සෞඛ්‍ය පිළිබඳව වැඩසටහන ක්‍රියාත්මක කිරීම සඳහා. දැනට එහි අධ්‍යක්ෂ විදියට ඉන්නේ Dr. රෝහන් රත්නායක. He is the pillar behind this program. The major strategies of our mental health program, one of the major strategies is to prevent suicides. Then promotion of mental well-being, prevention and control of substance use, strengthening human resources, and infrastructure, monitoring and evaluation of mental health program. අපේ ප්‍රධානම කාර්යභාරයක් තමයි සියදිවි හානි කර ගැනීම වළක්වා ගැනීම අපේ මානසික සෞඛ්‍ය පිළිබඳ වැඩසටහනේ. Then to conduct this program, we have the mental health policy, which is effective for 10 years from 2020 to 2030. And our vision is to provide optimal mental health and psychosocial well-being. අපේ කාර්යභාරය තමයි ලංකාවේ ඉන්න සියලුම ජනතාව සඳහා උපරිම මානසික සෞඛ්‍යයක් මනෝ සමාජීය යහපැවැත්මක් ඇත් කර දීම. For this, we are creating an enabling environment to create mental well-being and also to prevent mental health conditions, treatment, to provide rehabilitation, and also to facilitate psychosocial care. And the main objectives of this policy to conduct these mental health programs, to strengthen the leadership, and also we have to look at the legislation, do research, and also provide a service that is socially and culturally acceptable. And again, to strengthen the human resources, infrastructure, and also finally, to empower the communities in promoting their own mental well-being. And as I said before, suicide prevention strategy is also under the mental health policy, which is in effect for the next 5 years, that is from 2021 up to 2025. Advocacy, we have to look at the main focuses which we have in the suicide prevention strategy, that is advocacy, policies and guidelines, services, community support, psychosocial well-being, and surveillance and research. අපේ සියදිවි හානි කර ගැනීමේ වැළැක්වීමේ ප්‍රධාන උපාය මාර්ගවල තියෙන ප්‍රධාන කොටස් තමයි මම දැන් කිව්වේ. ඒ කියන්නේ අපිට අපේ වැඩසටහනේ suicide එහෙම නැත්නම් සියදිවි හානි කර ගැනීම වැළැක්වීම සඳහා ප්‍රධාන උපාය මාර්ගයක් තියෙනවා. First of all, we have to coordinate and strengthen the collaboration with a large number of stakeholders, because the reasons to commit suicide or to reason to end the life is not only health, it's 90% non-health. So only 10% lies with health issues. So therefore, we have to coordinate with a large number of stakeholders. Then we have to support and strengthen the policies and guidelines. We have to facilitate the provision of affordable, socially and culturally acceptable mental health services, which is accessible to all, and also promotion of psychosocial well-being. And then there is another strategy for institutes of learning, because schools, universities, vocational training institutes are a main sector where young people are gathered. So we have another special sector for a special strategy for these institutes of learning. Then finally, establishment of a surveillance system with a flow in information. Then I'll just go through the main activities, not all, but the main activities that we have for suicide prevention. We have an action plan and a strategy which we have formulated and presented in 2021. And now we are in the process of taking the action plan to different districts. We want the district mental health team and the district administrators to have their own action plan. ඒ කියන්නේ අපේ ප්‍රධාන කාර්යභාරයක් තමයි අපි අපේ Directorate එකෙන් එහෙම නැත්නම් මානසික සෞඛ්‍ය පිළිබඳ අධ්‍යක්ෂ කාර්යාලයෙන් අපේ වැඩසටහන හදලා තියෙනවා. නමුත් අපි හදපු වැඩසටහන අපි දිස්ත්‍රික්කවලට ගෙනහිල්ලා ඒ දිස්ත්‍රික්කවල ඒගොල්ලන්ගේ තමන්ගේම සියදිවි හානි කර ගැනීමේ වැළැක්වීමේ වැඩසටහනක් තමන්ගේම එකක් හදාගන්න කියන එක අපි අපේ වැඩසටහන පෙන්වුම් කරලා ඒගොල්ලන්ට ඒකෙන් කොටස් අරගෙන තමන්ගේ වැඩසටහනක් හදාගන්න කියන එක තමයි අපි මේ දවස්වල කරගෙන යන්නේ. The next is the psychological autopsy. We have developed a psychological autopsy tool in collaboration with the College of Consultant Psychiatrists. And a psychological autopsy, I quote, retrospective investigation of the intention of the person who committed suicide, unquote. ඒ කියන්නේ අපි කෙනෙක් මැරුණට පස්සේ ඇයි ඒ කෙනා මැරුණේ කියලා අපි ගිහිල්ලා ඒක හොයලා බලනවා. එතකොට මේ සඳහා අපි වෙනම ටූල් එකක් එහෙම නැත්නම් වෙනම දෙයක් හදලා තියෙනවා psychological autopsy tool කියලා. ඒක අපි අරගෙන ගිහිල්ලා දිස්ත්‍රික්කවලට දෙනවා. ඕගලන්ගේ දිස්ත්‍රික්කයේ ඉන්න mental health team එකත් එක්ක එකතු වෙලා මේ හැම suicide එකක්ම පුළුවන් තරම් අවුරුදු 18ට වැඩි හැම suicide එකක්ම ඉන්වෙස්ටිගේට් කරලා බලන්න කියලා ඇයි මේ සුයිසයිඩ් එක උනේ කියලා. ඒකට හේතුව තමයි අපි මේ දත්ත අරගන්නේ පොලිසියෙන්. එතකොට පොලිසියේ දත්ත ඉතා නිවැරදි. නමුත් හේතු සමහර වෙලාවට නිවැරදි නොවෙන්න පුළුවන්. ඒ හින්දා තමයි අපි හිතුවේ සයිකොලොජිකල් ඔටොප්සි ටියුල් එකක් අරගෙන ගිහිල්ලා ඒක ඩෙත් එක වුණාට පස්සේ සුයිසයිඩ් එක වුණාට පස්සේ ඒක ඉන්වෙස්ටිගේට් කරලා එහෙම නැත්නම් ඒක විශ්ලේෂණය කරලා බලන්න. දත්ත නිවැරදි වුණාට සමහරලාට හේතු නිවැරදි නොවෙන්න පුළුවන්. එතකොට අපි හේතුව හොයා ගන්න ඕන ඉදිරි වැඩසටහනේ මේ සුයිසයිඩ්ස් නැවැත්වීම සඳහා එහෙම නැත්නම් සියදිවි හානි කර ගැනීම නැවැත්වීම සඳහා කරන ඉදිරි වැඩපිළිවෙල සඳහා නියම හේතුන් හොයා ගන්න ඕන. මොකද මම අර කලින් කිව්වා වගේ 30% එන්නේ අද කියලා. අද කියන්නේ හේතුවක් හරියටම දෙන්නේ නැහැ. එතකොට ඒ 30% ඇතුලේ අපේ වළක්වා ගැනීමට සඳහා අවශ්‍ය ප්‍රධාන හේතුන් සැඟවිලා තියෙන්න පුළුවන්. Then another activity is to empower and strengthen our staff. That is medical officers. They are trained in diagnosis and management of persons with mental disorders. Then staff is again trained in substance abuse prevention, in child psychiatry and community mental health well-being. So therefore, what we aim is to have all the primary healthcare staff, the doctors who are working in primary healthcare institutions, they are able to diagnose and treat the persons with mental disorders. අපි ඊළඟ බලාපොරොත්තුව තමයි ප්‍රාථමික සෞඛ්‍ය සේවයේ ඉන්න සියලුම දෙනා මානසික රෝග හඳුනා ගැනීම සඳහා පුහුණු කිරීම. මානසික රෝග පමණක් නෙවෙයි නොයෙකුත් මත්ද්‍රව්‍ය භාවිතය, ඒ වගේම කුඩා ළමයින්ගේ තියෙන ප්‍රශ්න සහ කමියුනිටි එකේ, ඒ කියන්නේ සමාජයේ තියෙන මානසික යහපැවැත්ම පවත්වා ගැනීම සඳහා අවශ්‍ය පුහුණුව ලබා දීමත් අපේ එක කාර්යයක්. Another one is the ASTA training. ASTA is Agrochemical Sales Technical Assistance. We work very closely with the Registrar of Pesticides, and we are now in the process of training agrochemical sales technical assistants to identify people who are buying pesticides, so thereby prevent suicides, because pesticide is one cause which is responsible for suicides. අපේ කාර්යාංශයෙන් පලිබෝධක නාශක කාර්යාංශයත් එක්ක අපි තා ළඟින් වැඩ කරනවා. ඒගොල්ලන්ගේ පලිබෝධක නාශක විකුණන, ඒගොල්ලන්ට අපි කියන්නේ ඇස්ටාස් කියලා, පලිබෝධක නාශක විකුණන අයව අපි පුහුණු කරනවා. ඒගොල්ලන්ගෙන් පලිබෝධක නාශක ගන්න එන අය, නොයෙකුත් පලිබෝධක නාශක ගන්න එන අයට මොනවා හරි ප්‍රශ්නයක් තියෙනවා නම් නිකම්ම ඒක විකුණන්න නැතුව මොකද්ද ඒගොල්ලන්ගේ ප්‍රශ්නය කියලා හඳුනාගෙන ඒ සඳහා ඒ කියන්නේ ඒගොල්ලන්ව දැනුවත් කරනවා. යම් කිසි කෙනෙක්ට ප්‍රශ්නයක් තියෙනවා නම් ඒගොල්ලන්ට පලිබෝධක නාශක විකුණන්න එපා. ඒ ප්‍රශ්නය මොකද්ද කියලා ඒ මොහොතට හඳුනා ගන්න පුළුවන් නම් හඳුනාගෙන යොමු කරන්න කියලා. Another one of our main activities is the establishment of gatekeeper training. Gatekeepers are the ones who are working very closely with the community. It could be teachers, coaches, agrochemical sales assistants, pharmacists, prison officers, police officers, any person, maybe government officers who are working in the district secretariats, any person who is working very closely with the community. Gramaniladaris, Samurdiniladaris, then all the agricultural officers. So they are trained in the awareness programs. ඒ කියන්නේ අපේ ඊළඟ කාර්යය තමයි ගේට් කීපර්ස්ලා. ගේට් කීපර්ස්ලා කියන්නේ සමාජයත් සමග යාගින්ම වැඩ කරන අය. ටීචර්ස්ලා වෙන්න පුළුවන්. එහෙම නැත්නම් ස්පෝර්ට්ස් වලට ඒ කියන්නේ ස්පෝර්ට්ස් කෝචර්ස්ලා වෙන්න පුළුවන්. එහෙම නැත්නම් පලිබෝධනාශක විකුණන අය වෙන්න පුළුවන්. ඒ වගේ මේ ප්‍රිස්න එකක වැඩ කරන අය වෙන්න පුළුවන්, පොලිසිය වැඩ කරන ඔෆිසර්ස්ලා වෙන්න පුළුවන්, සමාජයේ මිනිසුත් එක්ක ළඟින්ම වැඩ කරන අය සියදිවි හානි කර ගැනීම සඳහා ඒ වැළැක්වීම සඳහා ඒගොල්ලන්ව දැනුවත් කිරීම. කොහොමද කෙනෙක්ව අඳුරගන්නේ, ඒගොල්ලන්ව කොහෙටද යොමු කරන්න ඕන, මොකද අපිට කොච්චර අපේ සර්විසස් තිබුණත් අපිට ඒ සඳහා අවශ්‍ය පහසුකම් තිබුණත් ගොඩක් දෙනෙක් ඒ තියෙන පහසුකම් ගැන දන්නේ නැහැ. ඒ හින්දා ඒගොල්ලන්ව දැනුවත් කිරීම තමයි අපේ ඊළඟ කාර්යභාරය. අපි මේ දවස්වල එක කරගෙන යනවා අපේ කාර්යාංශය. Then the helplines. We have the 1926 helpline, which is again decentralized and operating at district levels. And then the WhatsApp line is also there, 075 555 1926. අපිට තියෙනවා මානසික සෞඛ්‍ය පිළිබඳව helpline එකක්. 1926. එතකොට මේක දැන් දිස්ත්‍රික්ක වලට ව්‍යාප්ත කරලා තියෙනවා. එතකොට මේකත් අපි මේ දවස්වල කරගෙන යන දෙයක්. ඒ සඳහා අවශ්‍ය කාර්ය මණ්ඩලය පුහුණු කිරීම, ඒගොල්ලන්ට පුහුණු වෙච්ච අයට නැවත පුහුණුව ලබා දීම සහ ඒක ප්‍රශ්නයක් නොවි ක්‍රියාත්මක කරගන්නේ කොහොමද කියන එක මේ දවස්වල අපි කරගෙන යන දෙයක්. Then the community health centers. This is a pilot project. We have at present around 50 community health centers. They are the ones attached to the medical officer of health at district levels. And all the community health programs in the medical officers of health areas are conducted through these community health centers wherever they are established. අනිත් එක තමයි අපි කියන්නේ ප්‍රජා සෞඛ්‍ය මධ්‍යස්ථාන. දැනට මේක ආරම්භක අවස්ථාවේ තියෙන්නේ ලංකාව පුරා MOH 350ක් තිබුණාට දැන්ට අපිට තියෙන්නේ ප්‍රජා සෞඛ්‍ය මධ්‍යස්ථාන 50ක් පමණයි. මේකෙදි ප්‍රජාවත් සමග වැඩ කරන්න අපි අපේ සෞඛ්‍ය සේවා අධ්‍යක්ෂ කාර්යාලවලට තියෙන MOH ඔෆිස් එකට අපි අනුයුක්ත කරලා තියෙනවා ප්‍රජා සෞඛ්‍ය කාර්යාලයක්. මේක හරහා අපේ ප්‍රජාවත් සමග වැඩ කරන්න කියලා අපි උනන්දු කරනවා. ඒ සඳහා අවශ්‍ය පුහුණුව අපි ලබා දෙනවා. Then for schools, we have the school mental health program. Again, we are doing this in collaboration with the College of Psychiatrists. At present, principals and teachers are trained on different aspects of mental health. මේකත් අපි ළඟදී පටන් ගත්ත එකක්. අපේ පාසල් සෞඛ්‍ය සඳහා අපි teachers ලවත් ඒ වගේම principals ලවත් zonal directors ලවත් අපි පුහුණු කරනවා ළමයින්ගේ මානසික සෞඛ්‍ය ප්‍රශ්න අඳුනා ගන්න ඒගොල්ලන් යොමු කරන්නේ කොහොමද ඒ පිළිබඳව මේකත් අපි ළඟදී පටන් ගත්ත වැඩසටහනක්. එතකොට we have the challenges. So working with the community and working with preventing suicide is a very difficult thing. So there are multiple challenges, but I would only speak about two things. One thing is working with media. Second is reaching the unreached. Working with media is very difficult. Even though we have a media guideline, media is not sticking to that guideline. So I hope by working closely with the media, we had 2 workshops in the beginning of the year, and we have established a media WhatsApp group where we communicate closely with the media people. And that again is challenging. Then reaching the unreached, that is, we have still not reached the homosexual groups, that is lesbian, gay, we call it the LGBTQI groups. So that again is challenging. Then final one is the future direction. One thing we are hoping to have a good monitoring and surveillance system, and psychological autopsies is the first step in that. Then evaluating the role strategies and early identification, treatment, and referral of people or persons with mental disorders. Those are the ones which we are going to have a specific actions in future. And finally, generally the final slide is a thank you slide. But as I have thanked the Sri Lanka Sumithrayo in the beginning, I would like to end this presentation with this. Suicide is preventable. Create hope through action. And thank you for giving me this platform. Thank you for all the listeners. මං හිතන්නේ මේ සියදිවි හානි කර ගැනීම වළක්වන්න පුළුවන්. ඒ හින්දා අපි බලාපොරොත්තුවක් ඇති කරගන්න පුළුවන් කුඩා ක්‍රියාකාරකම් කළා ජීවිතය සමබරව තියාගනී කියලා මං හිතනවා. I have given this picture to have a balance in life. When you have a balance in life, be it work-life balance, be it social and work balance or whatever, when you have a balance in life, that can prevent suicide. So I'm hoping that by creating little actions, we can have a balance in our life and it can lead to prevention of suicides. Thank you.
Thank you very much, Dr. Shiromi. That was very, very insightful, especially the details you shared with us about your planned intervention programs, which I hope will bring in the benefits you're looking at. Just one suggestion, and I would like you to also consider looking at data of attempted suicides, which is that data is really not coming out from anywhere, and that would help all of us to really understand the real pulse of the people. And I'm not really sure how that can be monitored or how the data can be extracted, but I do hope you can try and kind of, find a way of monitoring attempted suicides in some way island-wide, because I think that will give us the correct picture of mental health situation where suicide is concerned.
Yes, thank you. We have actually MHMIS, that is our information system, and we are collecting data through our clinics, but it's not a complete data because some districts are still not giving data completely. So we have to establish it, and also in some districts like Monragala, they have already started 6 months of collected deliberate self-harm data. So I think in future, that is what we are going to do in Gampaha and Kurunegala, because they are topping the list in suicide.
Yes.
So we want to look at the deliberate self-harm data, as you said, in those districts, and then maybe have a complete revisal of our strategies, maybe, or partly revise our strategies in the coming years.
Thanks. Also, Dr. Shiromi, another important challenge would be following up the attempted suicides and checking on their mental well-being, and because since people who suicide have attempted before, so the risk of suicide is always there for them, so they need to be monitored very closely. Not sure, it's a very, very difficult challenge, but maybe we should find some way where we can monitor people, where they have to keep coming back to the clinic, and some sort of evaluation can be done. Anyway, I leave it to your good hands to look at that. Thank you very much again. So I will move on to the questions from the panelists. A request to all of you who have zoomed in to click on the Q&A if you do need to ask any questions, and they will be answered either in between or at the end of the questions. So please do ask your questions, because the panelists will be very, very happy to answer them for you. So as Dr. necessary for preventing suicide in the community, which are primary, secondary, and tertiary. Dr. Neil, can you share with us your thoughts on how primary interventions can be implemented? Which is really primary interventions will seek to educate all in our community about suicide awareness. Dr. Neil?
Yeah, thank you. Thank you for your question. Actually, the answer to that comes from the WHO itself, because they have put 4 strategies that have been recommended for suicide prevention. I think we need to take note of that. The first is actually, am I able to share a slide with you? Is that
Of course you can.
okay? I hope you can see this slide.
Yes, we can see it.
Okay. Yeah, this WHO recommendations that I am going to speak of, it is actually named as LIFE. The 4 recommendations are named as LIFE, L-I-F-E. Now, what it means is actually, you can see it in this slide. The first recommendation is to limit the access to the means of suicide. Now, this is a very important strategy, and Sri Lanka has been quoted worldwide for being successful in implementing this strategy. The evidence for that is actually we were able to limit the use of pesticides. Firstly, by restriction on importing pesticides, and secondly, by also restricting the use of pesticides. Now, if I can show this slide, which is actually given in the WHO leaflet, which goes worldwide, they have taken Sri Lanka as the example. Now you can see the suicide rate was highest in Sri Lanka in 1995. And with the restriction of the pesticides being imported, which you can see in the downward arrows, you can see how the suicide rate came down drastically. Now, in 1995, the suicide rate, as Dr. Shiromi said, it was over 8,000, close upon 9,000. That is 24 suicides per day. That is 1 suicide per hour. And we topped the world in that year, the suicide rate. Now, it has now come down to, as Dr. Shiromi has quite clearly shown, it has come down to around 3,000. Now, anyway, there are 3,000 suicides. That's something that we have to take note of. But at least it has come down from close upon 9,000 to 3,000. And this drop is mainly attributed to the control of pesticides and the limited use of pesticides. So the first strategy that the WHO is recommending, limiting the means of suicide, access to the means of suicide, has resulted, according to the WHO calculations, about 93,000. We have saved 93,000 deaths from 1995 to, I think, 2050. During that 20 years, 93,000 deaths have been prevented. Had the trend been going on, there would have been 93,000 more suicides, right? So I think that is an important strategy. Of course, it is not only about pesticides. We now have to also think about other means of. Now, different countries are using different methods. In countries where firearm suicides are common, use of firearms as a method of suicide, restricting the sale of firearms have resulted in a drop in the rate. Similarly, also constructing barricades where people use very popular places to jump to their death, like bridges and things like that, constructing barricades that will prevent a person from jumping. So things like that have been used and has been found to be effective. So that's the first strategy. Then the second one is again very important, which was also mentioned by Dr. Shiromi. Interact. So the I stands for interact with media for reporting suicides, responsible reporting of suicides. Now, that is a very, very important thing. Reporting of suicide, it has been very clearly found, can lead to increase in suicides as a result of imitation. That's the main form. So that is one aspect. Other thing, of course, by describing the methods of committing suicide can also promote this. But on the other hand, the media can also be used in suicide prevention. For example, giving them alternatives to suicide, right? This dissemination information which can be taken as alternatives to suicide. Where to call for help in a situation. What can be done? How people have coped better with similar problems. Those are things that the media can also be used to actually educate. So media can be used for both aspects. Irresponsible reporting will lead to increase in suicide rates, but responsible reporting can also help in suicide prevention. So media is, I think, an important stakeholder. And whatever it is, I think from 1998 onwards, the Ministry of Health has been having a dialogue with the media. But I also agree that still responsible reporting has not taken place by and large. And so probably we need to continue this dialogue, interacting with the media. Third one, life is actually the F is to foster socio-emotional life skills. This is to develop life skills among adolescents. How to cope up with problems, how to manage problems, how to cope with emotions, things like that. Life skills education is something that has to be done, which has been started in schools, but has been given a sort of a low priority. So it has really not made any impact. So probably life skills education, not only in schools, but also in tertiary education institutions like universities, technical colleges, and various other places where youth are met. So probably that is something that again we need to do. And that's another community development. That's the third recommendation, which we have already started, but it needs to be done in a better organized way. And the last one is to actually, what we have been always saying, to identify people with high risk of suicidal behavior. So identify them, and actually not only identify, also to care for them. So that is the 3 C's that we usually talk of. Connect, communicate, and care. So first to identify and then to look after them. So probably these are if you take the WHO recommendations, I think it answers your question about what we can do in the community in suicide prevention. I think your mic is muted, I think.
Doctor, may I add? that also the removal of the stigma associated with seeking help for mental health concerns also should be a kind of a priority, because that restrains people from really seeking help.
Yes, definitely. Definitely.
Thank you. And I think all the rest of it are in place. Of course, we are all exasperated with the media for good reasons. We'll get on with, thank you, Dr. Neil, for taking us through the primary interventions. Dr. Ganeshan, can you, the secondary interventions target those who had particular risk of suicide? For instance, like people with unemployment, financial debt, substance abuse, chronic pain, or living alone, etc. Can you share with us your thoughts on how secondary interventions can be implemented, Dr. Ganeshan?
Yes, thank you for that question. So this follows up on what Dr. Fernando said. Again, how do we as a community look at these people who are at high risk? So when I say community, it includes the family members, friends, and the overall community. So the problem is, what is our attitude towards somebody who doesn't have a job? What is our attitude towards somebody who is suffering economically to meet their needs? What is our attitude to somebody who is using alcohol or other substances? Unfortunately, the attitude is very different. So they are already suffering a huge amount of trauma, huge amount of difficulties, disconnected from their natural kind of a network of people who are there to help them. Any of us, when we have problems, our natural support system, the family is the kind of a closest. And then we have friends, and then our work colleagues, etc. But unfortunately, we are very easy to judge somebody else and label them as bad, useless, or cruel. I don't know. We use different names. And it's very easy. In a way, it kind of helps me to focus on my values and my morals by saying, oh, that man is bad. When I say that man's bad, even though I have some temptation, I'm reinforcing my ability not to use it. That's true. But am I actually helping that person? So one thing we need to remember is we need to learn to see all human beings as equal, whatever the problem we have. Marginalized in society, but we need to learn to respect everybody else. And that is very important. And unfortunately, one of the bad things about this is...
Doctor, may I interrupt you? There is some concern that people can't hear you.
Okay. Now, is it better?
Better, much better.
Yeah, okay, thank you. So basically, I'll repeat. So one of the effects that happens because the way we marginalize people, people who are different from us, because how we treat them differently. We ignore them, we don't respect them, etc. It has a horrible effect that when I have a problem, I am going to feel awful bad about myself. right? So there are people who come and say, Doc, I am useless, I am worthless, right? Academically that well. So I am valueless. I am a disgrace to my parents. So even when the parents are not ill-treating, we put down ourselves so badly because from very early childhood, success is defined as a particular thing, academically or financially. He's not doing well in studies. We come out with these statements without realizing our kids are actually listening at home. They are taking it in. And when they grow up, that's the way they are going to see others. And also that's the way they are going to see themselves. And this is something that we cannot treat with medication or whatever. So this attitudinal change with substance misuse, which is true, which is a worldwide phenomenon. Now, how can they access help? Whom they can ask for help? The immediate circles, as I said, the family, the friends, the neighborhood, they are all pushing them to a side, when somebody goes to the OPD and says, hey, I have been taking heroin or cannabis or whatever, how are the staff, minor staff there at the entrance going to treat them? How do we see them? So when I say I'm dependent on alcoholic, I'm having tremors, I need to see the doctor. How is the staff going to treat me? How is the doctor in the OPD going to treat me? Are we welcoming them? So though we say we have a free health service, which is fantastic, but how accessible it is emotionally, physically it is fairly accessible, but emotionally and respect-wise, how accessible it is. What sort of language gets spoken in the outpatient departments? Are they using respectful language? So there are other things that look very small things, look very simple things, but are very key in making sure the real people who are marginalized, who actually need our help from accessing services. So that is very, very important. Another group that was mentioned was people with other chronic disorders. Unfortunately, our Sri Lankan health service is very good treating acute conditions. But when it comes to chronic disorders, unfortunately, I think, this is my personal opinion, we don't do a great job. People with chronic painful diseases like arthritis, spinal disorders, there are diseases that can last for a long time. How good are we in pain management? Chronic pain is one of the important factors in people committing suicide. And somehow, as a culture, as a society, we still have some reluctance in giving adequate pain relief for our patients. I mean, simple thing like, delivery time, delivering a baby. How good is our pain relief regimes? So we have a lot to do in that area because large number of chronic diseases do cause disabling long-term pain. And also the disability of unable to move, support. I mean, caring for somebody who is disabled with a stroke or something like that is quite stressful for the family. And unfortunately, the families do come out with statements like, you are useless, you are a burden to us. It can be very, very traumatic for somebody to listen to that sort of thing. How much support are we providing for the families who are caring for somebody with a disability. It can be intellectual disability, it can be physical disability. How much support are we providing? Because they are the backbone of providing services at home. Where are all of our stroke patients? Where are all of our serious head injury patients? They are all at home. They're not in hospitals. They're all at home cared for by families. And how much support do we give them? We don't give them enough. So we have a lot more to do in these areas to actually make people more kind of inclusive society, where everybody feels they are respected, they are cared for, and whatever basic things that they require, the society as a whole is aware of it and trying to address it. So I think that is key.
And may I ask you whether it's appropriate to add to the secondary intervention area elderly people who are isolated and living alone, and also people who have suffered sexual and physical abuse?
So, as I said, there are many groups like that. Elderly, earlier in those days, people were in an extended family system, the children were with them. But now it has become nuclear family. Elderly people are finding it struggling. And with large number of people going to work in Middle East and other countries, they are forced into a kind of a care role to their grandchildren alone with financial difficulties. And they have nobody to go to the hospital to get medication. And they are suffering a lot. Absolutely, yes. And also, the other area that you talked about, right? Sexual abuse, childhood sexual abuse. Unfortunately, it's still pretty common.
And domestic violence too?
Domestic violence too. So, unfortunately, we have failed to develop adequate child-centered services from reporting onwards, right? So even if we report a case of child abuse, how much re-traumatization the child goes through, how much suffering the child goes through, and how many children we see 13 years, 14 years carrying their babies, their right to education is stopped, and they are ostracized again, horribly ostracized by the families and the communities. So we have a long way to go in understanding that people in difficult circumstances are going to behave differently, not because of the fault of theirs, but because as a society we have failed to provide them an adequate, suitable, happy environment to grow in, and all of us are responsible.
Yes, thank you, Dr. Ganeshan, for taking us through the secondary intervention area. I would like to, Dr. Shiromi, can you hear me?
Yes, can hear.
Okay, Dr. Shiromi, I would like you to take us through the tertiary intervention, prevention intervention programs, and to also highlight a few areas because these are necessary for people with very high risk factor for suiciding. That is the crisis management or follow-up care programs for patients with recent suicidal attempts, which I spoke to you before, or deliberate self-harm, and all
Doctors are trained, and they are also based in all these hospitals to treat, and then back referral is also there. But I feel, as Dr. Ganeshan said, we need to develop communication and attitude skills, which we still have not attempted, which we are still depending on the attitudes that we have gained right through our life and through the medical studies that we have done. But all the doctors who are appointed as MO mental health, they are given a 6 weeks training on mental health and also mental health promotion, because our directorate is mainly doing the preventive care. So therefore, we are now concentrating mostly on prevention, on mental health promotion. So we have now started this mental health promotion skill development, and also we are collaborating with the National Institute of Health Science to do the mental health promotion. So I think in future, most probably we will have this. We'll have doctors with much more developed mental health promotion skills. So, and other than that, I think all the hospitals, they have their own consultant psychiatrists. Of course, now the number is dwindling because of migration, but they have the consultant psychiatrists and the mental health teams. All the districts have their own mental health team, consultant psychiatrists, the nurses, occupational therapists, social healthcare workers, and all of them are giving the preventive care. And we have the specialized institutions, then the institutionalized, the safe environment. All that is already there, but we need to further develop it. And also it is accessible, but then the services, as I think the two consultant psychiatrists said, the services need to be further improved.
Okay, thank you very much, Dr. Shiromi, for sharing that very important information with us. Dr. Neil Fernando, Sumithrayo, as well as other stakeholders, have relentlessly tried to educate the media on how a suicide should be reported without glamorizing it or giving graphic details of the method used, because providing details of the mechanism and procedure used to carry out a suicide may lead to the imitation of suicidal behavior by other people at risk. So, above all, if a suicide helpline is given at the end of the report, it will help other vulnerable people with suicidal thoughts to make contact and prevent an impending suicide. Dr. Neil, I would like to discuss a particularly disturbing report that was published a few days ago by a reputed daily newspaper. Your views on this can cover two areas of concern. So I would like to share the document with you. So this was published, Dr. Fernando, on the 7th of September.
Yeah, can I comment on that? Is it?
Of course, that's why I'm asking you to, because it's very important that we discuss this in detail.
Yeah, the first thing that I would like to say is that now by reporting this kind of information, the survivors of the immediate family, a lot of people do not think about this. The immediate family are in grief due to this incident. And their grief is actually aggravated by such reporting. Negative reporting, it actually aggravates their own grief. They themselves are in a grief because of this sudden, unexpected loss to their family, whoever. So, and also by giving details about the area, the police station, it tends to identify people. So that it becomes then a problem to the survivors, the immediate survivors, who are anyway affected psychologically. And so that is one aspect of reporting such things. That's number one. Number two is, of course, it clearly describes how the suicide took place. It says how it happened, describes in words. And that is another well-known thing. When you describe a method, that method can be imitated by other people who are potentially having suicidal ideas, secondly, having a similar problem. So it gives another way of, it gives a way out, in other words. So that's
Also revenge, no, doctor?
Yes, yes. So it actually advertises in a form of advertising what to do in such a situation. And also what the reasons that are being given in, I think in the paragraph, the one before the last, the paragraph describes the reasons. Now, these are very superficial reasons, usually brought up at the time of the inquest. You know, all suicides will have an inquest, and this inquest is done by the police, and we all know how this inquest takes place. So there has to be some reason given, and usually the reason is the immediate reason. But suicide is more complicated than that. There are so many underlying factors, so many contributing factors, right? And none of those things are being mentioned. So it is not, it has not been investigated. It's only the superficial things. So by giving these superficial things, which may be true, but may have been a minor contribution, there would have been underlying major reasons for this whole affair to have taken place. So trivializing a suicide for a reason or two is also not the correct way of doing it. So actually it carries misinformation about suicide, right? Misinformation about suicide, and there is no guidance for a person who reads this what to do actually in a situation like what is the alternative to suicide. That has never been mentioned here. So this is where I think we need to improve on the quality of reporting. Now, another thing, because I have been involved in this media, education and guidelines from way back in 98. Now, what I found was that now when it is reported in the printed media, actually the headlines are decided not by the person who is reporting. Headlines are decided by the sub-editors. And unfortunately, none of the sub-editors have attended our what we call training workshops. It is always the reporter who actually, the area reporter who comes, who have been fairly educated, but ultimately the heading is decided not by them, but by the sub-editor, who always includes something that carries some sensationalism. That they say the word that they use is to increase the news value of the report. So that is an area, I think, Dr. Shiromi, if you are working with the media personnel, especially the print media, I think we need to somehow get down the sub-editors. They have never been to this is my experience, for any of these training programs. So that's an area probably we have to work further. But I also agree that media has a definitive role to play actually in preventing suicide. And they can help us to actually do this in the responsible reporting of suicide.
Also, doctor, two things that struck me were the language using the word illicit. It's very judgmental, for one thing. And
The
also,
words that
sorry.
those are the words that are added by the sub-edit actually.
Yes, and there is no helpline at the bottom to address
Yes.
vulnerable people. And also, this is giving people ideas that if your wife is
Yes.
having an affair, you can take revenge by taking your life with a child. Don't you think so? It's a very frightening situation.
That's why I said it is a form of sort of advertising, promoting.
Yes, so there are two tiers to this newspaper article. I want Dr. Ganeshan to look at the next one, which is also very, very disturbing. That is the comments by the community on this article. So the first one is, what an idiot. What 6-year-old did. You could have handed over the poor girl to grandparents or police. No wonder the wife was having an affair with someone else. How do you deal with people who have the capacity of taking their life of their own children as they cannot deal with their insecurities? Affairs happen, so learn to deal with it. It's not a crime. Generally, all those housemates from Sri Lanka working in the Middle East have sexual relationships with other males. This is a common fact. Never mind that man jumping. Why take the life of the innocent girl? So unfortunate. He is worse than the wife. So heartless to take the life of a 6-year-old. May his soul rest in peace. A valuable lesson for others. With all due respect to the involved woman, that man should have known that there is not just one fish in the ocean. In life, this is called freedom. She should enjoy her freedom as the man already had his. So, Dr. Ganeshan, what do you think about these comments from the community? Probably so-called civilized people who are reading these articles and responding.
So this is where I was saying how we need to start working with small children about how we look at another person's suffering. Right? For whatever reason, this man who committed suicide, killing his own daughter, what the amount of suffering that he would have gone through, the self-doubt, the questioning, he must have been suffering for days and weeks, the most severe form of suffering before he actually did this, right? He didn't do that very happily or very happy about what he did, right? So this judgmental attitude, very happy to condemn other people without realizing exactly what has happened to these people. I mean, as Dr. Fernando said, this is just the superficial surface of the issue we are talking, right? But already people are like, how many generalizations people have talked. Imagine the number of housemaids who have been gone to work to the Middle East or whatever. How are they being looked at, right? And like, how is they are looking at the wife and how? So this is the problem. So even the media, the reporters or the sub-editors or whatever, they also come from the same society that we are seeing here commenting. Right? So the general attitude, when it is so bad, we expecting sub-editors to be somehow to be looked at as saints or whatever, it's not going to work. Right? So we have to start working from childhood onwards, adolescent onwards, to have a proper attitude towards other people and other people's suffering. Right? So the problem is, again, now we have another problem. Earlier, we only had the print media. Now, very few people look at the print media. Now, the social media platforms are completely unregulated and they can come up with all sorts of things. About this particular incident itself, we don't know what the social media came out. So, unless we deal with the whole society as a whole, trying to kind of look at only the media or only the health staff is going to be very challenging, right? So, I mean, the media, when you ask them, they say, Doc, if you don't publish, somebody else is going to publish. We are in a competitive field, right? So, we can't be nice guys here. So, you give us a good statement to make. So, sometimes the media does reach out to me. And when I say, do you have to really publish this? Why are you doing this? They say, Doc, if you don't publish, somebody else is going to. At least we are asking you. Give us your comment, we read it. So we have to engage with them on their terms, dictating them what they should do, what they shouldn't do. is going to be very difficult to manage, especially so with the social media coming. Now, earlier we had 1 or 2 news channels in the television, 1 or 2 newspapers. Now there are many-fold and the competition has really ballooned. So it's very difficult. So we have to learn to work with them.
Okay, thank you, Dr. Ganeshan, for that. So although it's very, very disturbing, we have to move on and hope that things can change in our country. Sometimes you get very, very disappointed because every single year we are doing the same thing. We are trying to educate the community as well as the media. But sometimes we feel that we have failed when we read things like this. You know, it's a very sad situation. Anyway, let's move on to the next question to Dr. Neil Fernando. Dr. Neil, people often slip into anxiety or distress trying to control things that are out of their control. Like, for instance, what people think of them, what others feel or react, brooding over the past and pondering about the future. I came across an interesting graphic that shows all of this. Doctor, how must we distinguish between what's within and what's outside our control, and importantly, reduce our anxiety and distress? I will share this with you. I thought it was very interesting. Do you feel that people can drift into anxiety and distress by trying to control things that they can't control, Doctor?
Yes, that's actually part and parcel of life, actually, right? We all fall into these situations in our daily life. So emotions are natural, and they are what is important is how people should deal with these emotions, and especially to teach people how to help a person in an emotional situation, right? Now, at least we have started teaching medical students and other health workers like the nursing students about how to deal with emotions through communication. And to put it very simply, there are 2 important skills that you need to develop. First is to acknowledge the emotion. So if a person is distressed, the first thing that you need to tell that person, communicate, is that you have understood this distress. You have recognized the distress. And that is called acknowledging. So the first thing is to acknowledge. Yes, I can see that you are distressed, or I can see that you are anxious, or I can see that you are sad, or I can see you are angry. That is very important. So ability to recognize the emotion and acknowledge it. So that's the first skill. These are very simple techniques, but unfortunately, I have not been trained to do these things. Secondly, once you acknowledge, the second step is what we call validate it. Validate the emotion. It's very important. Another term that has been used is to normalize it. For example, saying that, yes, I can understand that you are angry, and it is natural to be angry in this situation. If I had the same problem, I would have also been angry. So that is to normalize it and to validate it. And these are 2 important steps in actually helping a person with emotional distress. Acknowledge and validate. It's very, very important. Very simple, very easy to carry out 2 skills, which will actually help the person who is in distress to feel that at least this person has understood me. And this is what we call empathy. So this is the way to show empathy, understanding with regard to emotions. So dealing with emotions, I think that is an area unfortunately not being managed or not being given emphasis in our training. We were never trained during our time in these skills. And it is only now that these things are being looked at. This comes under communication. If you look at our training, most of our training is about diseases. From day one, we are being taught about various diseases, but very little time is spent on the person who has the disease. So we are not being told about the person who has the disease. So we know everything about the disease, but not the person who has the disease. And this is one area that we need to develop. So my simple answer would be that people will have emotions, people will be distressed. And this is the communication that is the second C that I said in the 3 C's: connect, communicate, and care. And this is the communication that is important. Communicate that you have understood the person and also validate the persons. So you are looking from the person's point of view. And the distress is acknowledged and validated so that the person will feel better. And that is the way to help people.
Thank you, Dr. Neil. Fernando, Dr. Ganeshan, would you like to add anything to this?
No, I mean, that is important. I mean, the emotional intelligence, learning to connect with our emotions and accepting our emotions as valid, and then learning to manage those emotions in a sensible manner, least harmful manner, is something that we need to teach our children, right? Unfortunately, for some funny reason, these very important things are left out of our school texts.
Yeah.
And so because expecting parents to do this is very challenging. Where there are some parents who are capable of understanding it and capable of giving it to their children. But
yes,
expecting all parents to do this automatically, it's not fair. That's what schools are for. To give a uniform education, a uniform knowledge base to our children is the purpose of our schools. And unfortunately, what happens is there is massive discrimination. Parents who are educated, who are knowledgeable, are able to give this. But other parents who are struggling through life, working very hard, their children don't get an opportunity to learn these things.
Yes.
So we need to get this into school. So that is something we have to do it. And other countries have done it. This is not some rocket science that we need to do first. Other countries have done this. And we see the results.
Thanks, Dr. Ganeshan. Coincidentally, I was going to ask the 3 of you a question on emotional intelligence. So I think I'll go through with it now since you have brought it up. And it seems to be the ability to understand and manage your own emotions and those of the people around you. And I think it came up in the mid-1980s after the book published by Daniel Goleman. It is said that people with emotional intelligence know what they are feeling and what their emotions mean and how these emotions can affect other people. And there are also 5 domains of emotional intelligence. So maybe, doctors, you could share your thoughts on this if I share the screen so that you could look at each of these domains.
Sure. Yes. So I think self-awareness, Dr. Fernando has already talked about it. It's very, very important we are able to name the emotion, right? So unless we name it, I won't know what I'm going through. So teaching children, your own children, the names of different emotions, and to say, I'm angry now, I feel sad, I'm annoyed, to use these words at home, in Sinhala or Tamil, to put a name to the emotion you are having so that the child also learns to do that. So the child, rather than throwing a tantrum, will say, I am angry now. I am annoyed. I am irritated. So once you put a name, that is the first thing for us to manage the emotion, to come to the second thing. So as Dr. Fernando said, teaching this to medical students who are already 23 years old, right? It shows how lacking we are in our homes and schools, right? So you would expect people at that age to know this, but unfortunately they don't. So this is absolutely the first thing. And then what are the healthy ways we can manage the emotions? There are healthy ways and unhealthy ways of managing emotions. When we use unhealthy ways of managing emotion, then it's going to make our problems worse. Right? So we see drug abuse, alcohol use, attempting suicides, hurting somebody else. These are some of the really bad ways of managing our aroused emotions. Of course, there are better ways of managing emotion, and children, people need to learn what are the ways. What are the, even when I ask people who are professionals, what are the ways you reduce stress? They're not sure exactly what I'm asking. Of course, all of us have felt stress, right? In multiple different ways. And I need to have my own healthy ways of reducing stress. It can be going for a walk, it can be listening to music, it can be talking to a friend. I don't know, it will vary from people to people. But even professionals don't have a list they go to when they are under stress. And see what I can do now. Very simple thing. And teaching this to our children is very, very important, right? And of course, yes, motivating oneself and understanding emotions of others and managing them. So these are very simple things that people can be taught. So unlike IQ, intelligence, which part of it we are born with, emotional intelligence is, we can learn that 100%. We don't need to be born with it. So my parents can have really bad emotional intelligence. I can be good at it. So it's very easy to teach children, and children will learn it very well. And we see that other cultures doing it.
Okay, thanks, Doctor. I would like to ask Dr. Shiromi the next question. In Sri Lanka, suicidal behaviors often arise impulsively, with little or no warning, or even with no history of depression. A family quarrel or a sudden disappointment might cause feelings of suffering, frustration, anger, leading to an attempt to self-harm. Suicidal thoughts can develop in a matter of hours or even minutes, leaving very little time for family or friends to see the danger signs and intervene. Because the idea of suicide arises suddenly, people don't have time to reflect on their thoughts and try to speak to someone before self-harming. This difference can pose real challenges for suicide prevention in Sri Lanka. Dr. Shiromi, how can interventions be made between the precipitating event and the resulting act of self-harm?
Yes, now it's a very, very interesting question. And I think prevention should start at the preschool level, because it is too late to start at university level or school level. If we start our preventive actions at preschool level, rather than teaching the preschoolers to write letters, rather than teaching them to, prepare them for school first year entrance examinations, if we teach them the emotional intelligence, that is to identify their own emotions, express their own emotions, I think that is the point that we should start. And that is why we are having trouble as adults. That is why it is very difficult to teach these things to university students, medical students, and also school level, even though we are teaching them life skills, it is very difficult. And that is why people go into suicides. Because as you very correctly said, people do not know how to manage their own emotions. They do not know what protective mechanisms are there within us. We are built with mechanisms that we do not understand. We do not know our own powers because we have never been taught those things. So I think starting at the bottom, that is starting at preschool levels, educating the preschool teachers to teach the children, because it is very easy to say, you know, the parents should teach their children, and that is very easy. And if the parents know how to do it, I think that is very easy to do. But the majority of parents, I find, they do not know how to handle their own emotions. So I think asking them to teach their children, because it's impossible. So I think starting at the bottom level, at preschool level, is the way forward.
Thank you, Dr. Shiromi. So I will ask Dr. Neil one more question, which is really about what Dr. Ganeshan also brought up in the beginning. Sumithrayo is mostly concerned about the feelings of our callers, which we help them to explore. And by the way, Dr. Neil, what you said about validation and acknowledgement is a part of our befriending process. Otherwise, we can't befriend them without that. And it also includes things like reflective listening, active listening, non-judgmental listening. So it's all a part of the way we engage with people who seek our help. So people may slip into distress when their feelings are hurt and self-esteem affected, especially when parents, spouses, and teachers may label them. Stigma often emerges in the form of derogatory language and labels that shames people, remains with them all their lives, and are very, very difficult to remove. For instance, slow learners are compared with the performance and achievements of other children, while their real strengths are undervalued and remain unappreciated. Dr. Neil, your thoughts on this?
Yeah, I think Dr. Ganeshan actually answered this very, very clearly. This
In the beginning.
is about making judgments, prejudgments. Yes, in the beginning, right? So we first judge, and then we decide based on our judgment. We try to evaluate people. So that is the problem. So as I think Dr. Ganeshan very correctly suggested, this should begin at family level, where actually how children are brought up and how the parents should actually, the parents are the best teachers of the children.
Yeah.
So looking at people in a more respectful way, being able to recognize emotions, common emotions, and be able to actually express your emotions in a more appropriate way. So these are all things that these are interconnected, but which needs to be actually inculcated during childhood, and especially in early childhood. So the best way to do that is through showing. Now, for example, we know that parents who show kindness to other people, the children will also follow the same pattern. That is a well-known thing, right? Because they learn the importance. Now, it's another important thing is to be helpful to people who are weak, or who are disabled, or who are sick, things like that. So we need to teach them through our own examples. So that is I think the best way to teach, because children will observe and learn, and of course the parents can of course tell them why it is important to do these things. So what I feel is that, as Dr. Shiromi also suggested, preschool period can be actually used in a more meaningful way, in actually showing these what we call these are called soft skills. That is the word that we use now. Soft skill, developing soft skills, so that we will not be hurting people when they are hurt. Now, that is what happens normally. We tend to hurt them more when they are hurt. So that is something that we need to change. And yeah.
Dr. Ganeshan, what would your message be to parents who compare their children, a child who may be a slow learner for some reason, and compared with the performance and achievements of other children, while the real strengths of that child is undervalued and remains unappreciated? That often happens in today's community, Dr. Ganeshan. I mean, I've seen it happening around me too. But what is your message to parents? Do they realize the kind of damage that they can cause the child by stigmatizing the child in that way, shaming the child?
So I think, this what you said is a very common phenomenon that we see across all the kind of different ethnicities or cultures or city, village, everywhere, rural, urban, everywhere we see this phenomenon. Unfortunately, I think why they are doing this is they think out of shame and guilt, the child is going to improve their performance and they are going to see some immediate gains. So they are probably looking at kind of an immediate benefit by, better school marks or whatever, without realizing what a child gets for maths or science or Tamil or Sinhala when they are in grade 4 doesn't determine their future at all, other than boost the parents' egos. So the problem is they need to understand when you undermine somebody's self-concept, when you undermine somebody's self-worth, they are going to do a huge amount of harm for this person when they grow up. They are going to be very shy. They are going to be ashamed of themselves. They are going to be ashamed and guilty of making even smallest mistakes. They would stop trying. And it's going to condemn their lives for a long, long time to underachieve. So though we say some people are slow learners, others, everybody has a different talent, right? Sometimes somebody who is not doing academically well can do very well in sports or music or something else. But by undermining their self-worth, you're making them just not good at anything. So, and also it leads to these other behaviors, like you said, deliberate self-harm, suicide attempts, completed suicide, everything. So, being hypercritical of your children, comparing your children to another child just because you are angry, your child has not got enough marks for whatever subject, it's not really worthless. Do you remember how much you got for, I don't know, Sinhala or Tamil when you were in grade 4? You don't even know the marks we got. How is it impacting on your life today? It has no impact on your life today. So just because we think it adds prestige to say to other people, oh, look, my child got 95 or whatever, it's not worth damaging a kid for the sake of that. And parents need to be told this in schools, everywhere possible, that this does cause damage that is very, very difficult to repair later on. Right? So we can have very good mental health service. We can have hundreds of psychiatrists. We can have large number of counselors, whatever we do. Once the damage is done, the repair work is very, very difficult. It's very, very difficult. So prevention is the best thing we can do. And it's very simple.
Thank you very much, Dr. Ganeshan, for those very insightful comments. And I hope parents who are listening in will take note. There are 5 questions that have come in, and I will read them out. The first one is regarding the suicidal ideations due to mental health conditions. What measures have you taken to encourage the patients to identify the conditions early before it is too late? Dr. Shiromi, would you like to answer that? I'll read again. Regarding the suicidal ideations due to mental health conditions, what measures have you taken to encourage the patients to identify the conditions early before it is too late?
I think the best person would be the two consultant psychiatrists to answer that, because we are in prevention and like we don't carry out programs to identify.
Okay, what about Dr. Ganeshan or Dr.
Yes,
Neil?
yeah, I'll answer that. So,
Okay.
I mean, one of the things is we have a very good distribution of mental health services. So, as Dr. Shiromi said, we have district-based units and we have outreach clinics. So, the service is quite widespread, and it is something that we can really be proud of. But unfortunately, yes, still there is a bit of overcrowding, and also, as I said earlier, how welcoming is the health service to the clients and how respectful we are and how confidential are our services. How are we, somebody can talk to me in a clinic without others listening to. So those sort of physical environments are unfortunately still lacking. And also the emotional environment could be better. But there is another problem. How many people with depression and anxiety actually seek health service? How many people know that it's a mental health problem? And how many of them feel confident and comfortable to deal with their self-stigma and the possible stigma from others and reach out for help? So that is another problem we have. Our treatment gap. The number of people with depression and anxiety who are there in the community and people who are actually seeking help, is a gap. And we need to narrow that gap. And that's where the telephone helplines, all those things come in useful. So telling them this condition is transitory, it will go away with treatment. There are very simple ways of treating it. And yes, in some of these conditions, you can have suicidal ideation, but that doesn't mean that there's no way out and that is the only way. That suicidal ideation is caused by this illness, and when we treat, that will go away. So raising the awareness of the client or the patient and telling them this, then giving them confidence that it will go away. And also to some extent, educating the family members with the consent of the client so that they will keep an eye out and make sure that some protection until the treatment plan starts working can go a long way.
Okay, thank you, Dr. Ganeshan, for that very detailed answer, which I hope.
Can I?
Yes, of course.
Also about the ideas, about suicidal ideas, thoughts. Now, generally what happens is that these ideas tend to gather momentum, that you become increasingly or frequently you get these ideas. So that's a thing that can be mindful of, that if your thoughts are coming frequently about ending your life, and also thinking about how you should end your life and things like that, when you get plans about how, and when you become more and more preoccupied about the end, these are things that I think can be actually discussed, so that people are made aware, not only the persons, but also the immediate family members. And there are a lot of myths about suicides. And these are also things that we need to deal with. So now some people think that people who say that they want to commit suicide never do that. That is general understanding. And it is also, there is another myth saying that asking about suicide will encourage suicide. Things like that. So these are areas that I think we need to actually address and educate and increase the awareness, the myths and the facts about suicidal thinking. Yes.
Thank you very much, Dr. Neil. I think the next question is directed at Dr. Shiromi. Do we have the resources, especially human resources, to implement the mentioned actions in our society?
Yes, I think, of course, human resources, if you I won't say adequately available, but given the current situation, yes, we have resources, and we are like, say, if you think about counselors, we don't have counselors in our health system. So we take them from the economic affairs and the social services ministries, and the medical services are available from the health ministry. So I won't say it's adequate, but then resources are available and we have to use them efficiently to provide a service.
Thank you very much, Dr. Shiromi. Sorry. So the next question I would like to direct at Dr. Neil Fernando. Suicide is a last resort when hope is lost. How can hope be restored to a person who has been cheated and no way to recover losses?
Yeah. Now, the first thing is that, as Dr. Ganeshan also mentioned, that this is a transient situation. That's number one that we have to remember. It's a transient situation, a transient state, so that there should be always hope. That's number one. Second is, of course, there are alternatives to suicide, right? What are the alternatives? So that is something that probably a person can discuss with. There are alternative ways of dealing with this situation, right? And also what we have to remember is that people who have committed or have attempted suicide also have a liking to life as well. It's not in one direction, right? The person who wants to kill himself is also has a liking to survive, live the life also. So that is something that we need to remember. This has been very clearly shown in research studies of suicide attempters, and where this the liking to live is also part and parcel of their thinking. So I think there is always hope, and we need to actually bank on that. So that is why we say that suicide is preventable. Statistically, yes, you can't bring down the suicide rate to zero. That is not possible. But if you take individually, there is always means of actually preventing suicide. So, and to prevent suicide, you need not be a professional, mental health professional. Anyone can do that, and that is the theme by through action, creating hope. And the three things to remember would be the 3 C's that I always remind people of. That is the 3 C's: connect, establish connections with people who are potentially vulnerable to suicide, communicate them in an empathetic manner so that they will feel that they are being understood, and of course,
care for them.
care.
Thank you very much, Dr. Neil. The next question I will direct at Dr. Ganeshan. Stigma is one main factor that discourages a patient to seek treatment or help. Can you please share the measures taken to reduce the stigma? Or
Yes.
probably they mean, can
Yeah.
you share what measures can be taken to reduce the stigma?
Yes, I mean, stigma plays a very important role in people not seeking help for mental disorders as well as suicidal ideation. That is true. So one thing that works is for people of prominent social status coming out with their mental health issues. And this we see a lot in the West. There are, famous personalities, presidents, prime ministers, famous athletes coming forward and sharing their mental health struggles. And unfortunately, I don't think those are reported enough in our local media, though they get very prominent display outside the country. And so that is very important. And also, we have to try hard and get our famous personalities to share with their mental health struggles, and some have done it, but it's not enough. So that is something that is going to be very important. The other one is, how do we treat people with mental health problems? One, within our health service itself. How welcoming are our services, how stigmatizing are our services. So unfortunately, we have a lot more to do in our health service itself. Say if you go to a hospital, when you go to a medical ward and a surgical ward, and you go to a psychiatry ward, do they look the same? Though we say, mental health is just another health issue, people are not going to believe us unless we demonstrate it. Unfortunately, we still have problems in bringing our quality of the infrastructure, the human resource awareness to the same level as the other sectors in the health facility. So that is one issue. Then, of course, general awareness of mental health. Now, physical health, there's a lot of things that people are taught in school, in hygiene and science and other subjects. But unfortunately, mental health doesn't get enough coverage in the school system. So people learn a lot of things, people practice is because what they hear, what they learn in schools. And we need to include more things about mental health in the school curriculum. That will also reduce stigma. And also, people allowed to work as volunteers in mental health systems, civil society movements, like somebody volunteering to work in your organization and similar other organization. When they come into contact with people with mental health issues, and they realize, they are just like anybody else. There's no difference. And that is another way that we can reduce stigma. So we need to work hard. We need to do more. So just saying, don't stigmatize people with mental health problems alone is not going to work.
Thank you very much, Dr. Ganeshan. Dr. Neil Fernando, we have 2 minutes for you to answer the next question. Can you please share what challenges are there in cross-cultural counseling in Sri Lanka and the measures that have been taken to reduce it?
2 minutes is the problem.
Because we have a deadline at 8. Anyway, you carry on, don't worry.
No. Yeah, I think we need to, counseling is something that is a very important thing, but I think still, this is my personal opinion, that people have not realized the importance of counseling and how it can actually help people. When I say counseling, it is not only for mental health issues, but counseling for other non-mental health issues as well as non-health issues. So counseling has a very large part, and of course, we need to have counselors properly trained to actually do this. So these are areas that we need to actually look for. And there was a idea of getting down counselors to the health service also. I think Dr. Rohan was talking about it, but still it has not happened. That is, I think, one important step in the correct direction, to have what we call clinical counselors in our system, where they can actually help people. So that is, and also in a multicultural society, the counselors also need to be sensitized into the different aspects of those cultures also, and the practices also, and actually learn to respect the people's practices as well.
Okay, thank you very much, Dr. Neil Fernando. As we are closing, I would first like to thank Dr. Shiromi, Dr. Ganeshan, and Dr. Neil Fernando for participating in this panel discussion, which has brought in a lot of new information. And I do hope that 3 of you enjoyed participating with us as you normally do, and look forward to seeing you again in the near future. Thank you so much. Thank you very much. I think we are on the correct time to light a candle to remember people who have taken their lives and to stand in support of people who have survived it.